This talk will cover patients with coronary artery disease and myocardial infarction. The difference between arterial sclerosis and atherosclerosis is something I think that we should talk about. Arterial sclerosis is part of the aging process. It's when the intimal lining of your artery, remember that endothelium I've been talking about, it loses its elasticity and weakens due to high pressure over time. It is a kind of a calcification of the arterial walls, and this is something that happens to all of us. Atherosclerosis, on the other hand, is the formation of plaque within the arterial wall, and this is what causes coronary artery disease. Both conditions begin early in life and progress without symptoms throughout adult life. So the pathophysiology then of the atherosclerosis is you get injury to the endothelium, and this causes inflammation and the growth of some scar tissue. The inflammation causes the development of collagen and fibrous tissue to form into a scar. Then you get plaque buildup. There's a fatty streak that will build up there, and plaque will deposit on that arterial wall. A fibrous cap develops, and eventually it can harden and calcify and cause turbulence or stenosis. Or the cap can rupture and form a clot, and this clot can clog your coronary artery or block your coronary artery and cause partial or total occlusion of flow behind the clot or from behind the stenosis. And that's what causes the problem then with coronary artery disease. Here you have a visual of what I was just talking about. The coronary artery disease, the coronary arteries can become damaged or diseased from that buildup of cholesterol-containing plaques or as a result of inflammation. So you've got the plaque forming in the lining of the arteries. It grows, the lining of the artery is damaged, the plaque ruptures, and then if it ruptures, platelets will try to repair it. And then because the platelets are there, they're sticky, they're starting the clotting process, and that can block the artery and lead to coronary artery occlusion, loss of blood flow, and a myocardial infarction. This is yet another really good visual of the progression of atherosclerosis with the fatty streak, the plaque, and then of course the complicated lesion there when the cap bursts and the platelets form a clot. These things really do a number on your coronary arteries, and your coronary arteries are not very big to begin with. So any occlusion and decrease in blood flow can be an issue. Coronary artery disease then is a progressive disease. It's a narrowing or occlusion of the coronary arteries, and the major factor is what we just discussed, atherosclerosis. The coronary arteries are responsible for supplying oxygen to the myocardium, and so when plaque narrows those arteries, that leads to diminished and insufficient blood flow. As the vessels narrow, then the patient experiences symptoms of ischemia, which is pain, that chest tightness and angina that people complain about. If plaque or a coronary artery spasm plaque can diminish the blood flow, or coronary artery spasm can also diminish the blood flow. A sudden obstruction, which is what we talked about earlier when that plaque ruptures and there's a clot, that will cut off blood supply completely to the cardiac cells. That's when the infarction occurs. It can come from that rupture, or it can come from an embolus from somewhere else, but usually it's the atherosclerotic plaque that is the bad actor there. Older adults have less coronary artery blood flow just because they're older and they've got less blood flow in general, so they have less reserve, and any added oxygen demands can compromise cardiac circulation. And so they just in general have less cardiac reserve than their younger adult counterparts. Non-modifiable risk factors you're probably aware of already. One thing I do want to point out that there are higher risks in African Americans, particularly in African American males. Modifiable risk factors should also be pretty uh, familiar to you by now: diabetes, hypertension, cholesterol, alcohol, obesity, sedentary lifestyle, stress, and of course, tobacco use. This covers lipid lowering drugs, and it's here to remind you that lowering serum cholesterol and triglycerides is very, very important to controlling coronary artery disease and preventing heart attacks. So the statins, of course, are the ones that you're the most familiar with. There's some lists of other ones here. I'm not going to go through and talk about all of these. I will say that it's very important that you are well versed in these drugs because a lot of people you're going to be taking care of are going to be on them. Important points about nursing management for coronary artery disease, of course, is education about medications, taking their statins, lowering the fat and cholesterol in the diet is very important. But something that people need to be aware of is that diet alone isn't going to get this if you have a genetic issue. Cholesterol is that you eat is plus or minus 10% of your total cholesterol. If you have a genetic predisposition to this, it's a problem with cholesterol production in your liver, and your diet is not going to be able to take care of all of it. And so that's why a statin is necessary. And there's been really, really good research done on this. And it's important that people understand yes, diet is important and they need to make a concerted effort there, but it should also be done in conjunction with the medication if indeed they do have the genetic component to it. Lifestyle and exercise state changes, including exercise, also very important here because exercise increases that high density lipoprotein form of cholesterol, which is protective. So the signs and symptoms of coronary artery disease are basically angina and its associated symptoms. Um, so chest discomfort, it's a feeling of tightness, aching, burning, pressure that often radiates back through to the jaw and the arm, left arm frequently, sometimes to the back. You'll get dyspnea, shortness of breath. Sometimes it will be on exertion, sometimes it will be at rest. Palpitations or tachycardia, nausea and vomiting. In fact, sometimes that's the only symptom somebody will get is the nausea and vomiting, and that's true oftentimes of women. They get diaphoretic, their skin gets really cold and clammy. Another thing that happens with women is that they have a lot of tiredness and fatigue, very unusual weakness and inability to complete their usual activities of daily living without chest pain or dyspnea. Several different types of angina. You can have stable or exertional angina, which means you get chest pain with exertion and it stops at rest. It's relieved by rest or nitroglycerin. You can have a variant or a vasospastic angina, which is angina that happens a certain time of day, no matter what you're doing, and goes away on its own. That's usually a vasospasm, hence the name vasospastic. And then unstable angina is angina that is usually starts out as stable, doesn't always, but usually does, and then it progresses to angina at rest, and that is always a trouble sign. The diagnosis here, of course, is an ECG. Sometimes they'll do an exercise test or a chemical stress test, nuclear imaging, angiography in the form of a cardiac cath. If they are ruling out an MI, they will do a cardiac lab panel. We'll talk about angiography later, but I just wanted to show you that this is what a stenosis of the left anterior descending coronary artery looks like. This is the problem. There's just not enough blood getting through. Medical therapy includes relieving pain and preventing damage, preventing anginal episodes. Those are some goals. The risk factors can actually determine the treatment because if you have hyperlipidemia, of course, that's going to be part of the treatment. If you're a smoker, have diabetes, overweight, sedentary, that's going to determine the treatment. So you're looking at some lifestyle changes, and then also medications, which are usually nitrates, which will dilate the coronary arteries. You've got a picture of Nitrostat, which is a sublingual nitroglycerin tablet here, and then Nitrodur, which is a nitroglycerin patch for longer term treatment here. The nursing diagnosis I have listed should probably make sense. Acute pain and anxiety is a very, very scary thing. People say they have a sense of impending doom when they're having a heart attack, and I believe that. Knowledge deficit. They need to learn about their medicines. There's a lot to know about taking nitroglycerin, and that's important for you to know the different kinds of preparations that are out there, different ways to take them, and different things that each kind of preparation is used for. Activity intolerance sometimes will cause people just to stop being active, which is, of course, absolutely the wrong thing. And then, of course, the risk for non-adherence to their therapy and some good education hopefully will help with that. This chart talks about the different kinds of nitroglycerin preparations that are available for use in anti-anginal situations. There is a short-acting that you use sublingually to treat or prevent attacks. You can also, it's a tablet, and you can also use a spray. And instructions are here on how to get it. One thing that you need to know is that if it doesn't burn, it's not working. These tablets deteriorate if they are not kept in dark places, and if they're stored in a warm, moist environment, and actually even if they're kept in a good environment, they still deteriorate. People will carry them around for months and months and months and months, and then all of a sudden use it and nothing happened. Well, it's because they're no good. So it should burn and it should give you a headache if it works. There's a spray canister that should not be shaken. If you are giving it to them, you want to take their apical pulse and their blood pressure before and after. They should take the pill, and if it's not relieved, call 911 before taking another one. And of course, use caution if you're male with erectile dysfunction medications, and also caution with alcohol, because use of nitroglycerin and ED meds and alcohol can severely decrease your blood pressure. It can be very dangerous. There are longer acting preparations. Isosorbide is a PO preparation. It can cause orthostatic hypotension, and of course it can give you headaches, although you can get used to the headaches, and quite often they will go away with Tylenol. And then there are the longer acting transdermal kinds. Transdermal patch is a very good thing to use. You want to remove the old one before you apply the new one. Rotate your sites. Be very careful handling them, because you don't want to, if you're a nurse, to get that on your skin and wind up on the floor hypotensive. Apply it to a clean, dry, hairless area. Very important if you've got men with hair on their chest or their arms. It's If you use nitrates 24/7, you get a tolerance from them. So a lot of times they'll have people remove these as beds at bedtime to prevent tolerance. The thinking there is, of course, you're sleeping and you aren't exerting yourself, so you have less risk for exertional angina. And if you are defibrillating somebody or somebody's going to go in for an MRI, you definitely want to remove that patch. Then there's also nitrobid ointment, which is it's not long acting. It's actually shorter acting. It's a transdermal preparation. It's absorbed directly through the skin immediately, and it has uses for angina and also uses, as we'll see later, for decreasing blood pressure in some other problems. Other drugs that people take, platelet inhibitors, aspirin or clopidogrel. You can use enteric-coated aspirin for daily dosing to protect your stomach. Sometimes ACE inhibitors will be used. Of course, you always want to check the apical pulse and blood pressure. There are orthostatic issues that happen. Calcium channel blockers are particularly good for vasospastic angina. Beta blockers decrease cardiac workload by decreasing the blood pressure and the heart rate. These are good for long-term therapy. And then Ranexa is a good anti-ischemic agent. It's really not as effective in women as it is in men, but it's really good for men because if patients take erectile dysfunction medication like sildenafil, Ranexa will not interfere with that like the nitrates do. And Ranexa is a daily pill. It's not a PRN take when you have angina kind of drug, rescue drug. It's not one of those. It's daily dose. Acute coronary system is a term that is used to encompass the continuum of coronary artery disease, angina, unstable angina, and myocardial infarction. We've talked about the CAD and the angina, and now we're going to move on to myocardial infarction. It literally means death of the myocardium, death of the heart muscle. And once the heart muscle dies, it's replaced by scar tissue. The amount of damage depends on the location of the coronary artery and the amount of blockage that's there. And so you can have a partial blockage of a coronary artery where some blood sneaks around and you don't have quite as big of an area of damage, or a complete blockage of an area where there's no blood and there's a lot of damage there. It's most often in the left ventricle, although you can have right ventricular infarcts. And the result depends on the speed and the effectiveness of treatment. With timely reperfusion, cell death may not occur, and that reduces the amount of permanent damage. So getting treated fast is what we need to encourage our patients and teach the public to do. There are two types of MIs, STEMI, which is a ST elevated MI, which we'll look at on an EKG in a minute, and a non-STEMI. And the one with the ST elevation is the more dangerous type. The other thing that people don't talk about a lot is sudden cardiac death in relation to MIs. but 50% of MIs present with sudden cardiac death. And so there's not a whole lot you can do about that other than CPR and a good AED. So that's definitely unexpected, no way to predict it. So here's your visual again of the decreased blood flow to the heart muscle and then the symptoms that that causes. So the chest tightness, pressure, squeezing, crushing substernal chest pain that's unrelieved by nitroglycerin or rest. So that's the difference there. If it's relieved by rest or nitroglycerin, you got angina. If it's not relieved, then you're probably having an infarct. You get dyspnea, nausea, diaphoresis, all the same associated symptoms as with angina. And as I mentioned earlier, just this feeling of impending doom, feeling like you're going to die. Older adults are less likely to have chest pain. In them, you're more often going to see indigestion, nausea, dyspnea, sometimes even confusion. Depending on the level of hypoxemia that you see. My grandfather, when he was in his 70s, he drove 17 miles into town from the farm, eating Tums because he thought he was having the worst heartburn of his life, and actually he was having a heart attack. Had no idea because he wasn't having chest pain. With women, you'll often see different symptoms. The American Heart Association has outlined this really well and has a great campaign, Go Red for Women, for women's heart disease. Um, As with men, the most common symptom is chest pain or discomfort with women, but they are somewhat more likely than men to experience the other common symptoms, particularly the shortness of breath, the nausea and vomiting, and maybe the back or the jaw pain. Also, uh, the fatigue is really big with women. Diabetics sometimes will have no pain at all because of peripheral neuropathy. They don't have pain and will have already had the heart attack and maybe have problems afterwards or even have heart failure and not even realize it because they never had the pain. I guess one thing about the chest pain is that the way that people describe it is so interesting. I've had people tell me it feels like they've got an elephant sitting on their chest. It feels like there's a vice around their chest that's squeezing. It's right smack dab in the middle of the chest, and the the radiation can go down both arms, most likely the left, but it can, and it can also go up to your jaw. You can also have shortness of breath with or without chest discomfort. And the diaphoresis is just immediate breaking out in a cold sweat. One cultural consideration, I mentioned earlier that there's a higher risk in African American males. Another cultural consideration is that they often experience dyspnea as the most acute symptom during an MI. More common than the classic chest pain in this particular ethnic group. And for this reason, they may delay seeking assistance because they may not realize what's happening. So that's an important teaching point in this population of people. The diagnosis, ST elevation is seen here on this ECG. You'll see where the QRS stops very high from the baseline and then moves straight on over to that T wave. That's classic ST elevation there, seen on an EKG. They will also do cardiac enzymes or biomarkers, and I'll say something about that in a minute. And then also cardiac catheterization and angiography is not only diagnostic, but can also be considered treatment because they'll do angioplasty and perhaps place a stent. So what I wanted to say about cardiac enzymes is, used to be creatinine kinase, or CK, was the first cardiac protein that was widely used by doctors to help diagnose the heart attack. It's an enzyme. And so enzymes are proteins, and they help bring about specific biochemical reactions. So for this reason, blood tests for diagnosing heart attacks were originally known as cardiac enzyme tests. So they would run what they called an enzyme panel. However, they've recently, well, not recently, but anyway, they have found that troponin is a very important blood protein that is used for detecting heart cell damage, and it's not an enzyme. It is troponins are a complex of regulatory proteins that are important to the contraction of cardiac muscles. And so because it's not an enzyme, most physicians now refer to these as biomarker tests or cardiac markers as opposed to enzyme tests. And I just kind of wanted to clear that up for you in case you were confused about the terminology. So we'll talk a little bit more about cardiac markers. So these are used to evaluate heart function, and they can be useful in early prediction or diagnosis of disease. Although they are often discussed in the context of an MI, other conditions can lead to an elevation in cardiac markers. So you've got troponin, creatinine kinase, and myoglobin. Historically, LDH was also used, but it's pretty nonspecific, so they don't really bother with it too much anymore. So these markers are released into the circulation when myocardial necrosis occurs, as seen in a myocardial infarction. So with troponin, the levels are normally low, so that this enzyme is undetectable in the blood. And if somebody's enzyme test comes back positive for troponin, they have likely had a heart attack or some sort of injury to the heart. As I mentioned earlier, it is the preferred biomarker used for this purpose because it is a much more specific and sensitive marker for heart muscle damage than creatine kinase, excuse me. Most doctors will still measure a troponin and a CK because whether measuring that CK adds much to clinical care is questionable, but anyway, most people will just still do it. Serial tests confirming when a heart attack has occurred often requires several biomarkers tests in a period over a period of time, demonstrating the typical rise and fall of the biomarker levels. Troponin is released into the bloodstream. Some people say 2 to 6, some people say 2 to 8 hours after heart damage, and the levels peak in 12 to 26 hours. And so as you can see from this graph here, there's a very typical pattern for each of these markers. So when are they most helpful? Well, if a patient has a typical ST elevated MI, then the ECG pattern itself, along with the clinical symptoms, are usually enough to make the correct diagnosis and to proceed on to treatment. And as you recall, correct diagnosis and treatment that leads to reperfusion is what's important here. But it's not generally, so if you've got that, it's not generally necessary for the doctor to wait for the results of the biomarker tests before initiating treatment. However, they are more helpful in people with acute heart attacks who don't have that typical ST elevation. People who have relatively non-specific ECG changes make it much more difficult to make a correct diagnosis. Therefore, the biomarker test is often critical in determining whether acute therapy for the heart attack is required in those people. The Joint Commission has a set of core measures for myocardial infarction treatment, and the theme here is time is muscle. So the more time you can cut off from symptoms to treatment, the more muscle you are likely to recover. The first thing they use is aspirin. It's usually chewed in the field if possible. Beta blocker started within 24 hours of arrival, and then they will add an ACE inhibitor or an ARB for left ventricular dysfunction if indeed that is present. A thrombolytic agent within 30 minutes of arrival is optimal. Primary PCI, which is percutaneous cardiac intervention, within 90 minutes of arrival is also optimal. That is fast, folks. But if you have an emergency department that is set up to recognize this and deal with it and get people into intervention, you can save muscle. They also then looked past admission to discharge. They'll put people on long-term aspirin therapy, beta blocker therapy, ACE or ARB inhibitor therapy at discharge, again, if left ventricular dysfunction is present, and then, of course, smoking cessation counseling. So that is the Joint Commission core measure bundle for someone who has had an MI. Immediate treatment for myocardial infarction, sometimes you will see the initials MONA, M-O-N-A, which is why I've got the little cartoon Mona Lisa here, which stands for morphine, oxygen, nitroglycerin, and aspirin. Not in that order, by the way. That's a good way to remember it. So as I mentioned, usually they will have the aspirin in the field, give the nitroglycerin. Hopefully with rest and nitroglycerin, the pain will go away, maybe not. Morphine relieves pain when the nitroglycerin is not effective. Oxygen is given usually only if the SATs are low. If the SATs remain high, they don't give oxygen so much anymore. Used to be they just slapped oxygen on without even thinking, but now they're a little bit more judicious with it. And since we have the ability to measure oxygen saturation in a very rapid and ongoing manner, it's easy to know. Thrombolytic agents, of course, once you get into the ED, sometimes people will need a pacemaker if they have a lot of irritability or if they have an infarct that destroys part of their conduction system. The acute care is usually done in the emergency department, and then after they go in for their intervention and hopefully thrombolysis, then they go to the ICU to be monitored because dysrhythmias can be life-threatening in the first 24 to 48 hours, and then after they have recovered from that, then they will do cardiac rehabilitation as an outpatient. So then to follow up on that a little bit more specifically, pain relief is very important. And so if the pain is not relieved by nitroglycerin, IV morphine is the drug of choice. Rest is so important. You have to decrease the workload of the heart, and one way to do that is rest. Medications and their side effects are something that you can be very aware of as a nurse, since you're the person who is going to be doling out the meds. If you're giving nitro, be very aware of the blood pressure consequences of that, especially if you are dealing with a man who may have erectile dysfunction, or if you're giving several nitroglycerin over a period of time. So frequent cardiovascular assessment, frequent vital signs, very, very important. Weight and I&O are important because you can go into failure very quickly after a heart attack, depending on how much cardiac muscle has been damaged. They always get a vascular access. In fact, hopefully they'll have one before they even walk in the door. They'll have one from the field. If not, an IV is the first thing that goes in. Their activity will be increased gradually after they have had their treatment, hopefully reperfusion, whatever. But for the period of time you would be spending with them in the emergency room, they are pretty much flat on the gurney. And decreasing anxiety is really important here because this is scary. This is I am going to die now feeling. And so anything you can do to calm them down, calm the family down, have the family stay with them, create a very quiet, low light, low level atmosphere, that would be good. Of course, that being said, what have you got? You've got nurses putting uh, leads on, nurses starting IVs, people pushing drugs, respiratories in there, getting oxygen started, labs in there, drawing blood. All, here, take this, swallow this, put this under your tongue. And so it is very difficult to maintain a calm atmosphere when somebody is having a heart attack. So the most you can do to look for calm in the face of the storm, I think will be appreciated by the person. Over the years, there's been a lot written about emotional and behavioral responses to myocardial infarction. This is certainly the closest brush with death that most people have. And everyone handles it in a different way. There is sometimes some denial that this has happened at all, and people will want to get up and go. There's nothing wrong with me. Go away. I'm fine. Um, they can be angry, very angry about it. This can be very similar, actually, to Kubler-Ross's stages of death acceptance. Anxiety and fear here are real because, again, this is always associated in people's minds with death. They can be afraid of dependency, afraid of being a burden on their family and friends, afraid of becoming handicapped or an invalid, and that's a real fear for a lot of people. A lot of depression occurs after a myocardial infarction. It's a real attitude adjustment for a lot of people, and some support groups and often some counseling is a good thing. And then hopefully they get to the point where they have some realistic acceptance of what has happened to them and what they can do in terms of lifestyle change and medication management to avoid it again in the future. I'll end with a case study here. 43-year-old woman admitted to the ICU with a diagnosis of atypical chest pain that radiates her left shoulder down her left arm. She's got a history of what she calls mid-sternal chest cramping or chest cramping right in the middle of her chest. Her pain increases with activity and decreases with rest. She smokes a pack and a half per day and is 50 pounds overweight. Right now, her cardiac monitor shows normal sinus rhythm with some ectopy, meaning those are little premature ventricular contractions every once in a while. She has sublingual nitroglycerin ordered for chest pain. 1 hour after she's admitted to the ICU, she reports acute mid-sternal chest pain radiating to her left neck and jaw. The cardiac monitor at this time shows ST elevation with occasional PVCs. Her pressure is 100/70, respirations are 20 and unlabored, and her skin is warm and dry. If you're the nurse here, what actions should be taken? Well, bed rest, vital signs for sure, before and after the medications that you're giving. So you're going to administer nitroglycerin per order, aspirin per order, administer oxygen depending on what the parameters are of your facility and what our oxygen saturations are. 12 lead EKG immediately and notify the provider. What are two possibilities here that could be causing this? Well, she could just be having some angina. That's a possibility. Or it could be an MI. How is angina differentiated from an MI? Well, nitroglycerin or rest usually stops the chest pain associated with angina. Neither nitroglycerin nor rest will alleviate the pain from a myocardial infarction. What are for indications or indicators that she's having an MI? So her history, the ECG changes that you see with the ST elevation that was described. If she had some blood drawn, she'd have an elevated troponin and an elevated CKMB, most likely. What medical interventions can be used for her? Well, she may need a nitroglycerin drip if her blood pressure is holding, if the sublingual is not working, and if she's still in pain. She may get some morphine if she has continuing pain. Anticoagulant therapy, the aspirin that I described, sometimes they'll do more of that. Also, thrombolytic therapy with fibrinolysis. They'll go in and try to lyse the clot. A cardiac cath will determine which artery is involved and the degree of blockage. And then if she has an intervention done, a percutaneous transluminal angioplasty, they'll put a balloon in on a cath, open the balloon, stretch out the artery, and then sometimes they'll place a stent. Sometimes this stent is impregnated with medication, and if for whatever reason either that doesn't work or there are too many blockages in too many places, sometimes they will do surgery. They'll do a coronary artery bypass graft. And then what patient education is indicated for her? Well, most definitely she needs to learn about smoking cessation if she doesn't know about that already. And it sounds like some weight reduction may also be a good thing for her. And then finally, a word about cardiac rehabilitation. So there will be a recovery period at home. As I mentioned, people often suffer from depression. It's important to, if they've had intervention, to teach them how to prevent infection to the surgical site and how to manage their wounds and to monitor for complications. Teach them about their medication, monitoring their blood pressure, heart rate, when to come in, what to look for, and then becoming involved with a cardiac rehab exercise program and support group can be really helpful for these people to get back on their feet and help them lead a normal life again.